This session is sponsored by Zydus, and I would like to call upon our speaker, Dr. Shirish Alurkar, Senior Medical Oncologist from Ahmedabad. Over to you, sir.
Thank you, Kashish. Very awe-inspiring video of Dr. Kanti Rai. Dr. Manoj, sorry I could not come to your yoga session today because I had few presentations. That's why I'm back here again. Anyway, I'm not a yoga person, more of a gymmer, you can say. Okay. So these are my disclaimers. This is the wrong presentation. This is the wrong presentation? Yeah, I have to change it. Otherwise, I'll not get my speaker fees.
So that speaks for your popularity, Shirish. Everybody, all the sponsors want only you.
Unfortunately, thank you. So what I will do is I will just focus on one molecule. There are various molecules on the spectrum of patients with HER positive breast cancer, be it an early breast cancer or a metastatic or a first line. So this is a biosimilar which was introduced by Zydus maybe a year back. And what I'll do is just review some of the literature, what is the basis of using this molecule in HER2 positive breast cancers. So this will be my flow of talk. And everyone knows that the US has approved various, US FDA has approved various HER targeted therapies way back from 1998 when trastuzumab came into the picture. And it was considered something like a tetracycline or something like an, you can say a molecule which changes the whole biology of the breast cancer. And coming down to 2020, 21 or 22, now we have various molecules. We also have a molecule for very low HER status recently approved. So TDM1 basically it's a technological product. By technological I mean it's a very elaborate way of making these molecules. These are all what is known as ADC, antibody drug conjugates, and it basically involves use of the good old trastuzumab on the left side along with a drug which is known as the payload, that is the chemotherapy part, which is the DM1, and you join these two with something known as a linker. There are various linkers available, and depending on the way of activity and the penetration into the cell, you can change the linkers and the whole molecule changes. So it basically uses the trastuzumab with the properties of the DM1 to penetrate into the cell. I'll just go into that. Yeah. So what happens here is when you give the antibody drug conjugates, it conjugates with the surface marker due to the endosome properties, endocytosis. The DM1, which is the chemotherapy part, enters into the cell, acts on the DNA and the mitochondria, etc., and then ultimately leads to apoptosis and cell death and whatever. And part of this drug also is thrown out by the calcium channels, therefore it acts on the surrounding cells, which is known as the innocent bystander cell. So there is always a certain amount of inherent side effects of the DM1, which leaks out of the cell, breast cell, and attacks the other nearby cells. That is known as the bystander effect. So what are the indications as of 2021? It's used in adjuvant treatment of patients with HER2 positive early breast cancer, and what is more important, they should have a residual disease after your adjuvant treatment. So after say new adjuvant treatment, you are giving surgery, and then you find that patient still has some disease remaining. Specifically, if you use trastuzumab initially, then what to do after that? In triple negative, we use capecitabine. In HER positive, we have the option of using TDM1, which is approved. It is also approved in another setting known as the metastatic breast, and this is either as a usually it is second line after previous trastuzumab based therapies or HER based therapies, and it is also now coming into picture as a first line therapy based on 1 or 2 trials. In India, it got approval in 2020 and is available for use since about 1 year back. So usually biosimilars are always compared to the innovator brands, and there's a very elaborate process of making this biosimilar, a lot of quality checks. There was this multi-center trial which was done to compare the efficacy of Ujvira, or that is the brand name of the Zydus drug or TDM1, with Kadcyla, which is the innovator brand, that is trastuzumab emtansine. And as these are the various parameters they study, the efficacy, safety, pharmacokinetics, anti-drug antibodies. So all these parameters more or less correlated with the innovator brand, and therefore it got its approval very early by the by the Indian drug regulatory authorities. So coming to the early breast cancer, what are the trials? As I mentioned, it is used in patients with early breast who have a residual disease. So there is something remaining behind on the histopathology after giving trastuzumab based therapy. So this is I will just focus mainly on the Catherine trial, which is more popular. It is basically a PCR based adjuvant therapy trial. So this was the trial. It was 1:1 randomization between TDM1 in the standard dose and trastuzumab, and the criteria of inclusion were basically early breast cancers who had a residual disease either in the breast or in the axilla, and after giving some sort of chemotherapy plus say trastuzumab. A good number of patients, a good number of large follow-up, and if one goes to the results, there was a the endpoint was an invasive disease-free survival. There are certain definitions of that. I will not go into that. It basically shows a considerable improvement in the IDFS, which is about 11%. You can see the delta here, a significant 50% reduction in the chances of developing an invasive disease in the future. Same way, as far as distant recurrences, again it has shown benefit, about 40% reduction in the chances of developing distant diseases. Are there any subgroup of patients which benefit? This is the typical what you call the forest plot. You can see the TDM1 is better in most of the subgroups, whether they are say node positive, they are ERPR positive, or they are ERPR negative. So most of the graphs are on the left side of the line of unity, indicating that it is definitely useful in most of the subsets. Does it really add to the trastuzumab? You are given trastuzumab, say, in an adjuvant setting or a new adjuvant setting, and does it really add to this thing? So if now in a new adjuvant setting, we either use trastuzumab or use the double combination of trastuzumab and pertuzumab, and then if there is a residual disease, we add the TDM1 based on the Catherine trial. How much benefit? About 10 to 11% over and above the previous HER therapies. That's the amount of benefit it can give to a patient. As far as the OS data, they are still little immature, so we cannot really comment. The p-value was not significant. Maybe more follow-up is required for that. I won't go into the attempt attempt trial in interest of time, because we are already going down. The other subset of patients are the HR negative, HR positive. So this is the very early stage. In this case, as far as the NCCN guidelines, these are all adjuvant systemic therapy after neoadjuvant therapy. They recommend use of TDM1 as a category 1. How long to give? About 14 cycles are given once the patient comes after surgery. So this is a proposed strategy in patients with early stage 1 to stage 3 HER positive breast. This is not the metastatic setting. So if you're in a very early stage, T1 disease on the left side, primarily surgery, you can even go for a trastuzumab based therapy followed by an adjuvant based on the HERA trial. If it goes to on the right side, slightly larger tumors, 2 centimeters or more, in such cases, obviously we use chemotherapy with say trastuzumab. See whether the histopathology shows any residual disease. If there is something in the tumor, a viable tumor, then we offer the patients TDM1 14 cycles depending on the affordability. If the patient has a PCR, then if it's HR positive hormone, we go for what we call hormonal therapy. There is still a role of extended HER therapy, but as neratinib, I will not go into the trial of that. So coming to the metastatic setting, we have done the adjuvant trial. Coming to the metastatic setting are the two main trials, which are the Emilia and the Theresa, or you can say Theresa, and another trial which is a Camilla trial, which is more of a clinical practice based or real life data sort of trial. So the Emilia trial, this is the impact. I will just go to these are two trials which are there as say second line. So your patient has received one line of HER based therapy, and now there is a progression of disease. As far as say about a couple of years back, if the patient progresses or has a metastasis after trastuzumab, we used to offer lapatinib with capecitabine. We didn't have any other option. It had lot of toxicities, so therefore it was difficult to handle these molecules, although they are oral molecules. So the Emilia trial, just focus on one of the trial, is again the randomization 1:1 TDM versus the standard of care that time, which was capecitabine lapatinib. And patients were of course HER positive, LABC or metastatic breast, a good number of patients, and these patients had progression after prior taxanes or trastuzumab. The primary endpoint was PFS by the independent review committee and OS in some cases. So these were the results. Definitely there was improvement in the PFS by about 3 months. I will not go into the detail, but if you just focus on the red line here, 6 months as far as the OS benefit is concerned, it looks small, but if you see, these are patients who have been heavily pre-treated with HER therapies. So this is all second line. As far as side effects are concerned, yes, there is some side effects compared to lapatinib, but my personal experience is easily manageable. Patients keep on coming, they just take the dose and go in an hour or two, and there's not much of an issue. Thrombocytopenia, yes, I had cases where patients have been persistent thrombocytopenia, that gives a lot of worry to them. They keep on calling, platelet count kam ho gaya, kya karne, but they're usually asymptomatic and managed with counseling only. The other trial was the Theresa, again a similar trial where they use, this is in second line, so 2 lines of anti-HR therapy, and then you give TDM1. Again, benefit, again 3 months of PFS, 7 months of OS, which was quite significant. These are all second line therapies. So what happens is CNS metastasis. This was basically a subgroup analysis of a Camilla trial, which is a phase 3B, a large trial, about 2,000 plus patients. This trial is more what we see in clinical practice. These are patients who are having a higher degree of tumor load. They have more visceral disease, they are more symptomatic, with these patients are usually not included in clinical trials, and therefore it more or less correlates to what is called the real world data. So in these patients also, in this trial also, which was found that the PFS, there was a significant difference, as well as the OS in difference. So basically, in those patients without CNS metastasis, the OS was about 29-30 months and the PFS was about 7 months. So there was a significant benefit also. This again shows, this is an exploratory analysis. Basically, it shows the because TDM1 has a good CNS penetration, that could be one of the molecule which uses for brain mets in HER positive. So what happens to the brain lesions, of course, after local therapy, is that there was considerable reduction as far as these forest plots are concerned. You can see there are more dips than the rises. So it does work with an overall response rate about 20%, and the overall clinical benefit rate, which is also includes the stable disease, about 43% as far as the brain mets are concerned. I think this is the last few slides. We have about 2 minutes. So Marianne study is one study which is the use of this molecule as a first line in patients with metastatic breast. So a patient has suppose not received any trastuzumab or any HER therapy. Can we offer TDM1? As of now, it is not a standard of care, but probably with this upgoing trial, we'll have better results later on. So this was again a 1:1 randomization between the standard, which is trastuzumab, paclitaxel, whichever taxanes you used, along with TDM1 alone or TDM1 with a double NTHR, which is pertuzumab. And these are all patients who have not received previous chemotherapy for the metastatic breast cancer. This is all first line therapy. The primary endpoint was PFS by the IRF. So you can see here there was a significant benefit in the PFS and the OS, although numbers look small. If you see the TDM1 14, the TDM1 only 14% is about 15%, but it just does give some support, some sort of encouragement that we probably can use TDM1 in an upfront setting in the first line cases of metastatic breast. Yeah, so as far as the guidelines, what the NCCN says for the invasive breast in second line setting, level 1 evidence for use of TDM1 as a second line setting. First line, it is still not come here, so probably a few years later this would probably come up into the first line setting here. So what do all the guidelines say? There are various societies, all of them more or less are on the same platform. The NCCN, the ESMO, the ASCO, they all say that yes, TDM1 is a preferred molecule in those patients who have received at least 1 line of anti-HER therapy, namely trastuzumab. As far as our patients in India is concerned, the introduction of this molecule in our Indian patients definitely has, we can use more patients, more molecules in these patients, because we can give the benefit to more patients because of the cost factor. And they have got a lot of schemes also. Probably the barrier to use TDM1 is broken, and now we can even give them for a longer period, especially in metastatic setting. Thank you.